All right, so let's get going. So this is the ECG that we have. So we have a 60-year-old woman with chest pain and severe dyspnea, gradually worsening for 3 days. And as usual, we'll analyze the axis, the rhythm, the rate, and then we'll analyze each zone. So you guys are welcome to jump in at any point and mention things that you would see. But let's go to the actual ECG. So here we go. And it is a scary looking ECG when you first look at it. But when you start, we have a look first of all at the history. So we've got a 62-year-old woman, chest pain, severe dyspnea, right? Gradually worsening for 3 days. So initially you have to start thinking about your differentials. And your differentials would be ischemia, and then everything that comes along with chest pain. So could it be a pulmonary embolus? Could it be a chest infection? Could it be a pleuritis? Could it be a pneumothorax? Could it be anything along that? And especially given that there is severe dyspnea involved as well, and it could be a lower respiratory tract infection. It could also be a pulmonary embolus, things like that. So it could just be ischemia with CCF. So these are the things that you have to think about while you're looking at the ECG. But what we're going to do is let's have a look first at the axis. So just to give us an idea of what's going on. All right, so we'll just draw that up. So we've got lead 1 over there and lead AVF here. Sorry. All right, so let's have a look. So let's look at lead 1. So you can see that lead 1 is definitely negative. So we've either got an extreme right or we've got a right-sided axis. All right, so we don't have a left-sided axis, and we definitely don't have a normal axis over here. All right. So let's look at lead AVF. So lead AVF is actually showing us a positive deflection. So if that's lead AVF, then hello, yeah, you're there. Sorry, if there is something, sorry, just put your hand up and I'll immediately see. And yeah, so we've got a right-sided axis. All right, so considering the history, we should already start thinking either of ischemia, left-sided ischemia, or possibly even a pulmonary embolus. All right, so let's just clear that out. So we've got a right-sided axis. Sorry about that. Okay. So people normally phone here thinking it's the urology clinic. I just let it ring. Anyway, yeah, so we're going to look at the rate next. So let's pick one over here. Let's look at this one here. So we've got 1, 2, 3. So we've got a rate of about 120. So we've got a tachycardia. Let's have a look at our rhythm, even though they don't give us a particular rhythm strip. But we can actually have a look at lead 2 here, just to give us an idea of what's going on. So when we look at the P waves, you see these very arched, tall P waves in lead 2. We notice them in lead V1. We notice them in lead V2 as well. In fact, in a lot of the leads, we can actually see these tall P waves. So I'm hoping you guys are already getting an idea of what the diagnosis should be. And then if we look at the PR interval, we've got 1, 2, 3, 3.5. So the PR interval is normal. We've got slightly wide, I would say borderline QRS complexes, but they still fall within the gambit of relatively narrow, but they are borderline. And, we've got a QRS following every P, and we've got everything happening in quite good rhythm. So except for the type of P wave that we've got, we do have a relatively normal rhythm, but that P wave is quite a big clue as to what we already have. Okay. And like we say, so we've got a tachycardia. Technically, we've got a sinus tachycardia. And then as we look through each zone, we need to start picking out clues from there. So if we look at the inferior zone, 2, 3, and AVF, you should be able to see already that we're seeing these inverted T waves. All right. So you can see we've got quite extensive inversions of the T waves all throughout. Very peaked, what you call it, QRS complexes there. Sorry about that. Sorry about that. Was just receiving a call. All right. All right. And what we can see over here, and I remember I was teaching you guys about looking at leads 1, AVL, and lead 3. So especially we want to look for left ventricular hypertrophy. And in fact, in this case, we can actually see right ventricular hypertrophy, where we see leads 1 and AVL actually pointing negative and lead 3 pointing positive. So that means we've actually got right ventricular hypertrophy. And we've got evidence of a straining atrium over here. We've got a sinus tachycardia. We've got these peak P waves. You guys should already be getting close to what the diagnosis should be. We've seen this before, right? But anyway, we've got these inverted T waves all along here. So it could still be ischemia, but especially with the right ventricular hypertrophy, chest pain, severe dyspnea, we should be thinking along other lines by now. Let's go to the septum itself. So in V1, we see this little right bundle branch block that's going on over there. In V2, again, we see these inverted T waves, also in V1. So we're starting to see these inverted T waves in V1, V2, in V3 as well. We see a little bit of maybe an ST depression over there. So this is the anterior segment. V4, we start seeing a bit of a ST depression, but again, we start seeing these inverted T waves. So I'm just going to stop here for a second because we've got a bit to discuss in this one. But remember what I told you guys, that if you've got inverted T waves in the anteroseptal leads, as well as the inferior leads, what we're actually looking at is most likely a pulmonary embolus. And in fact, 95% of the time, it ends up being a pulmonary embolus. So that inversion of the T waves is quite specific and sensitive. So considering the history that we have, it really is something that we have to look at. And we'll see the answer just now, and we'll see if we were correct. And then we look at V5, V6, the lateral sides. Again, we see these T wave inversions, very poor R wave progression over there, or very small R waves, if you can put it that way. And then if we look at leads 1 and AVL, we see very peaked T waves. And in leads AVR, again, we see these very peaked, what would those be, QR, R waves, okay. If we had to look at the pattern that we're seeing in lead 1, we're seeing a deep S wave. So you guys need to remember always that whenever we're suspecting a pulmonary embolus, one of the things is S1, Q3, T3. So we've got to check if we've got it here. So we've got an S in lead 1, we've got a Q in lead 3, and a T in lead 3. So we are seeing that. We're seeing a bit of a right bundle branch block. So we got all the signs of pulmonary embolus over here. So in this patient, what we would consider with the chest pain and severe dyspnea, our first and foremost diagnosis should be a pulmonary embolus before we start looking at these little ST depressions and things like that. Ischemia would definitely form part of it, but we would first start looking at a pulmonary embolus. And this patient's got a lot of signs of pulmonary embolus. We've got the right-sided axis, we've got the peak P waves or P mitralis, we've got the P pulmonale, P mitrale, and then we've got the S1, Q3, T3, we've got the T wave inversion. So we've got a lot that's supposed to show us that it's a pulmonary embolus. So let's have a look here. So we have a sinus tachycardia, the rate of 120 that we worked on, incomplete right bundle branch block, which we're going to get to just now as well. T wave abnormality consistent with inferior and anteroseptal ischemia. All right. But this ECG contains all the classic features of an acute massive pulmonary embolism. Tachycardia, right SWOOD axis, right bundle branch block, S1, Q3, T3, which is a large S wave in lead 1, Q wave in lead 3, and an inverted T wave in lead 3. Simultaneous T wave inversions in the inferior and anteroseptal leads. Okay. So we've covered pulmonary embolus quite a few times over the last few months, and it's something that we need to keep in our mind whenever we've got a patient coming in with any sort of chest pain, dyspnea, things like that. So we have to be aware that it is, it must always form part of our mindset whenever we're looking at the ECGs. So here we have the rest of it, which is massive pulmonary embolism, tends to cause an acute right ventricular overload and dilatation, which is what we have seen there, right ventricular stirring. It results in an incomplete or complete right bundle branch block pattern, which you're going to get to just now. The Q waves in lead 3 and AVF are not typical of MI type Q waves, which is true. Generally, those are wider. And simultaneous T-wave inversions in the inferior and anteroceptor leads should always prompt consideration of acute pulmonary, exactly what we were talking about. And acute pulmonary embolism should strongly be considered in any patient with a rightward axis or a prominent R wave in lead 1. So that not necessarily, but yeah, it needs to be considered, all right? So this patient was admitted to the hospital for evaluation of chest pain and dyspnea. Within an hour of her arrival on the telemetry unit, she suffered a cardiac arrest and died. The autopsy revealed a large lower extremity DVT, which had been producing a shower of pulmonary emboli, at least 5 noted at autopsy over the preceding days. So this is the type of patient that if you go back to the ultrasound lectures, besides looking for pulmonary embolus on ECG, we would then look at our flow in the deep veins of the leg. We'd then also do an echo to have a look as well. We'd look for things like McConnell's sign, right ventricular strain, things like that, right ventricular enlargement, right atrial enlargement, all the typical things that we had seen before. So even though today shouldn't have been too difficult in terms of the ECG, I just wanted to cover something that we have been seeing from time to time, but that I've sort of skimmed over because I wanted to spend a bit of time on it because I've noticed it's something that people do sort of worried about, you know. So the question is, when do we call, what is a right bundle branch block? How do we decide that something is a right bundle branch block? All right. So what are your ECG diagnostic criteria? So the first thing is to say it's a complete right bundle branch block, all right? You have a QRS duration of greater than 120 milliseconds, which is basically in V1 and sometimes in V2, we see something that's wider than 4 blocks. So our QRS complex shouldn't be wider than 4 blocks normally. So we see something that's 1, 2, 3, just over 4, right? RSR pattern in V1 and V3. Now, to remember that, just remember the M shape. So when you see this M shape in V1, V2, V3, and it's longer than 4 blocks, that's actually when we start thinking that this could be a right bundle branch block, all right? And a wide slurred S wave in the lateral leads, 1 AVL, V1, V5, and V6, all right? So in other words, this W pattern, although it doesn't always show up. So the easier one to actually look for is the the M shape in V1. The reason being that very often our patients present with multiple signs on an ECG. So it's very difficult sometimes, unless they've only got an isolated right bundle branch block, to be able to pick it up in the lateral leads as well. Excuse me. So remember, V1, V2 more especially, V3 depending on where you place the lead. QRS duration of greater than 4 of these little blocks, the RSR pattern or RSR prime pattern, whatever you want to call it, or the M shape, all right, in those leads, should start pointing in the direction of a right bundle branch block, all right? So here we see exactly what they were talking about. So associated features, appropriate discordance with ST depression or T-wave inversion in right precordial leads. So what they're talking about there is you generally get an inverted T-wave in V1, V2, and V3 when you have a right bundle branch block pattern. And discordance, it's often something that you may come across as you're studying ECGs. So discordance basically refers to which way does the T-wave point in relation to the ST segment in relation to the QRS complex. I don't want to get into it into too much detail now. We will cover it later on when we're covering left bundle branch blocks, but let's not stress about it too much at the moment. So what happens in a right bundle branch block? That's the question, right? So basically what happens is your heart is divided into 3 main bundles, all right? So in normal cardiac conduction, impulses travel equally down the left, right, and the right bundles, all right, with the septum activated from left to right. So that's normally how it works, all right? And the formation of normal Q waves, all right? In the right bundle branch block, the left ventricle is activated normally. So in other words, that starts working as it should, okay? But there is a delay of movement of electricity across there, okay? So in other words, it takes a bit longer for it to depolarize across the septum, all right? And this is what produces that second R wave that we actually have a look at, and sometimes a wide S waves. So it's a nice thing to know, but basically what they're trying to say is that that's the reason why I get the RSR pattern, okay? What happens is electricity travels down that side, and then it's struggling to get across there. So that's why it basically produces the pattern that it's causing. Right? So the normal activation of the left ventricle means the cardiac axis remains normally isolated, right bundle, branch block. And the thing is with right bundle branch block, a lot of the time it's an insignificant finding, especially when it's found on its own. It's not something that you should concentrate on or spend a lot of time on. It depends on the overall picture that you're seeing with the patient. So if there is history of ischemia, if there is history of chest pain, and you do see a right bundle branch block, you should still be worried. It's not to say you should leave it alone, but generally it's of no significance if you just do it and if you find it on a patient, right? So this is a nice slide. If you guys have a chance to come back and just read the entire thing. My apologies that I'm going a bit fast. We've just got a few patients waiting. So what is an incomplete right bundle branch block? So here we see in V1, we see that typical M pattern that we're talking about, the RSR pattern, right? So the difference between a complete and an incomplete right bundle branch block is just simply the duration. The incomplete right bundle branch block is within that 120 milliseconds. So in other words, it's less than 4 blocks, whereas with a complete right bundle branch block, it tends to go over the 4 blocks. So that's basically it. There's not much else to it. And you can see there's not much slurring as well that occurs in these leads. Now, I'm not going to spend too much time going through this particular ECG. It was just to show you more or less what an incomplete right bundle branch block, right? It's also a normal variant commonly seen in children of no clinical significance. So we don't worry too much about an incomplete right bundle branch block. And even when you do see a complete right bundle branch block, it depends on the setting that you're seeing it in as well. And it can be an inconsequential finding in a lot of patients. So this is just a joke to finish up. But my apologies in that we're not going to take too much time for questions today. But if you guys do have any questions or anything that you would like to know or anything, please send it to me later on the WhatsApp or the Telegram channel, and I'll try and answer it as best as possible. But I hope everybody enjoyed it today. I hope it was okay. And I'm going to post this on the group later. And yeah, we'll continue on Wednesday with some more x-rays. But unfortunately, I do have to cut it short today. I'm rushing back there. So thanks a lot for attending, those who attended on Zoom. And hopefully you learned a little bit today. Okay, thanks guys, bye.